We're going to leave medication management behind, and we're going to move more into a focus talking about communications with the members. And what do you imagine that there might possibly be some challenges when it comes to changing someone's medication regimen, especially when there are things like opioids involved? I'm imagining there's quite a few challenges with that. So we have a wonderful guest with us here today. I'd like you all to welcome Nadejda Razi-Robertson. She is a behavioral health consultant, and communication is something she's very attuned to on this subject. So Nadejda, I'll let you take it from here, and please give her a warm welcome.
Thank you. I saw a card this morning at the hotel I was staying at that says, "Life begins at the end of your comfort zone." So you all are bearing witness to my life beginning right now. Public speaking is something I'm finding myself doing a lot more of lately, and it is really among the least comfortable things for me. So here we go. I'm going to give you a little bit of history about myself, just to kind of share with you, what brings me here, and then let you know what we're going to be focusing on today. So I am a social worker, and I began my work in the realm of chronic pain during my first year of internship in this Master's of Social Work program. And I went to school through Portland State University, but they had a distance program, and professors would fly south to the Ashland area where I am living now. And my first year of internship, I was working in a community health center as a behavioral health provider, and Melissa was the office manager at that community health center, and I'm going to have her say a little bit more about her work shortly. And my supervisor at that time, Laura Hesacker, was one of the, I considered her to be really one of the primary pioneers in Southern Oregon, not only around kind of the development of behavioral health programs in our area, but also specifically around this issue of chronic pain. So I truly, just by the grace of the universe, fell into Laura's orbit, and since that time have been working with her, or closely with her, both as a behavioral health provider and now as a behavioral health consultant primarily. And I never would have expected that any part of when I was a little girl thinking about what I was going to do when I grew up, I would not think that I would be thinking about things related to chronic pain. That would be like opioids, like last thing on my radar. But here I am. And I want to start by telling you a story. About 10 years ago, I was working at a crisis relief nursery in Southern Oregon, and it was a program for children who had experienced really extreme abuse and neglect. And all of the children in this program, it was a program that served children 0 to 5, and all of the children in the program had significant developmental delays because of the adverse experiences that they had endured at their young ages. And during that time, I was before I went to get my master's, and I was working in a therapeutic classroom. And one of the things that we were asked to do was to start to kind of go to different trainings. And so we were trained in different behavioral therapies. The one I'm thinking of specifically was parent-child interaction therapy. And there were these behavioral therapies that were designed to really promote the kinds of behaviors that you wanted to see increase in children. I was getting all of this training, and I started to get very interested in the impact of trauma on the developing brain, and my inner life started to get really kind of activated by the experience that I was having working with these children. But I started to notice something when I started to notice the behaviors of children changing, and I noticed that what the people that were teaching me were talking about was like, that let's say if a child was really never made any eye contact. So what we would do is we would focus on anytime the child made eye contact. If we wanted to see more eye contact, we would specifically name that behavior. We would say, "I love it when you look me in the eye," or really praise the positive behaviors that we were seeing. And the idea was that would increase those behaviors in the child. And while I do believe that really was making a significant impact, and that those particular techniques were changing behaviors, there was something else that I started to notice. And I started to become very curious about this because I found that after a period of time, I would come to love a child. And there was an attachment and a bond that would happen between me and a child, and as their teacher and a person that was working with them very closely. And it was after that bond happened, it was after that relationship started to develop, that there were these dramatic changes in their development. So children, 4 or 5-year-old children who weren't speaking, once this relationship started to happen, all of a sudden there was a dramatic change, and maybe that child went from speaking 1 or 2 words to whole sentences or sometimes paragraphs, or really expressing themselves. And it didn't feel like something that I could really mention, and I started to just pay attention to it, but I thought, gosh, what is happening here? Anyway, years of schooling, et cetera, later, I was so pleased to discover that there's actually neuroscience that explains that phenomenon. And I remember I would get subpoenaed all the time, and I got thrown into this whole world of social service, et cetera, that I had had no prior experience in. And I remember thinking to myself one day when I was in court and the spotlights were on me and there were judges there and all of child welfare and lawyers, and this was, a big deal situation where it was a child custody case, and, the outcome of this particular hearing was going to decide where this child got placed long term. And I remember I'd get on the stand and they'd say, Miss Razi, would you please give us your credentials? And it was I remember thinking to myself, how many letters do I need behind my name before I can start to talk about love, before I can talk about relationship, before I can talk about, the underlying pieces that I really started to see that were really affecting these changes. Now, it did not cross my mind until 2 days ago because I've always felt like, oh, that was the world that I came from, and then it's so weird. I've found myself doing this chronic pain stuff. And it's always just been this sort of intriguing thing, like as if they're two kind of roads in my path. But I'm coming to understand something more and more, which is that actually there's something that is one and the same between these two areas. And what has really captivated my attention about this work with chronic pain is, again, this potential, this power that exists in the human relationship. And primarily between the relationship between the caregiver in this case. And I'm going to use the word provider, even though I know it's not. I think of all of us in this room as providers. We are care providers. We are health care providers. So there is an amazing possibility that exists in this relationship between us as care providers and our patients. And I didn't realize that now I am about to graduate, hopefully in May, with my doctorate in behavioral health, and I still don't feel like I have enough letters to feel totally comfortable talking about love, but I think relationship is one that I'm starting to get more comfortable talking about. So what we're going to be focusing on here is this little line between the care team values, the care provider's values, and the patient experience. So there is so much that we have learned and talked about already today, and there's so many areas that we could focus on. But today we are going to be focusing on this tiny membrane that is very potent, which to me is really about this relationship between the patient and the provider. It's also this place where many, we could call them opportunities. I would say it's many challenges arise also when we are talking with patients specifically about tapering off of opioids. And Rachel's presentation I thought was so eloquent and interesting, and I've heard a lot of people talk about chronic pain, but I felt like that just really encapsulated many things. So I want to just be really clear that the patients that we're talking about are patients that have centralized pain, that have been on these I'm looking at you, Rachel, because I want you to, that have been on opiate medications at least for long enough to develop some kind of dependency, so that those medications have been their primary form of treatment for managing, I'm going to go ahead and say, their emotional, psychological, and physical pain. And so that is the patient population that we are going to be focused on talking about today. Okay. I also want to now segue. I'm going to kind of do this in a few different steps, and we're going to land in some practicing around how to have conversations with patients, that you all are going to be doing the practicing. And I want to say that the work that I've been doing in Southern Oregon, there's a team of folks down there. Actually, show of hands. Is anybody working in clinics here where they have kind of implemented a ceiling dose, like we're not going to prescribe above? I'm seeing head nods. Okay, so y'all are, and that's been going on for some time? Okay, so in Southern Oregon, it was in October 2014 that the CCOs down there made the decision that they were no longer going to be covering above a 120 morphine equivalency dose. And some of the statistics that I have been hearing in the world where I work are things like 80% of all opioids are prescribed in the US. So we have, is that a true thing? Okay. Another one is in terms of this morphine equivalency dose piece, that the mortality rates start to really escalate once we're starting to get above 50 MEDs. And above 100 MED, it's 9 times higher. Death rates are 9 times higher. Pharmacists, people, am I correct? Yes? Okay. And so I think that there has just, in my understanding, is that there is this huge kind of push now that is starting to happen. I think Oregon and Washington have really been leading the way, but definitely there's starting to be this statewide and national push to start creating these ceilings to get our mortality rates down and start to increase other ways of, more effective ways of managing chronic pain. It's my understanding that at this time, the Center for Disease Control is going through a process of trying to figure out what their ceiling is going to be. Is it going to be 90 or is it going to be 60? I keep looking over there, like, right? Yeah. And I know that the Oregon Health Authority has also made it kind of a statewide mandate now that we will be trying to get all patients, not just OHP patients, down below this 120 dose with a real focus on moving towards closer to 60 in the next couple of years. So all of this to say that this is going to be affecting all of us if it's not already in your individual clinics. So I started doing this work. I was doing like some contract work with Jackson Care Connect and All Care in Southern Oregon, specifically beginning to implement this 120 MED policy. And it was very hectic, I would say, at first, because there was this process of like, okay, how do we let the doctors know that this is happening? And then so there was this, what had seemed like that there was a lot of preparation, a lot of efforts at educating providers, a lot of time and energy spent on kind of preparing the community for this change. What I observed was that actually having there were communication challenges. Somewhere on here, I think we've got a sticky that says communication challenge. Really, between the CCOs, the providers and the patients. And again, we are going to today be focusing on the provider-patient thing, but I think there is a lot here to be said about ways to really kind of more effectively think about how to get everybody on board with the education that's backing these changes in policies. Melissa, would you be willing to say a little bit about the work that you were doing at the Community Health Center back when I met you?
Sure. So as Nadejda just said, I worked at Community Health Center, and I was really fortunate to work with Laura Hesacker at a time when we were really starting to kind of look at this, what's safe prescribing habits, and when we actually had an issue where we didn't have appropriate provider staffing in our clinic, and so we were trying to manage our patients with kind of providers floating in and out. So basically what we had was I consistently had myself, Laura Hesacker, who was our LCSW, and a nurse. And we were trying to figure out how to manage our patients safely and effectively without consistent primary care providers. And so we really started developing what we called the Quality of Life program, which really focused on getting, are we paying attention to this 120 MED? What are we talking about as far as goals and where we're trying to get the patients, and really not just addressing their pain, but also their quality of life. That's why we called it the Quality of Life program. And so, so we really, Laura and the nurse that we worked with and I really developed that program, which kind of informed what became kind of a lot of the OPG stuff down in Southern Oregon. So that's kind of my background. It's interesting actually to look on the website and see that there's like forms that I developed and stuff, and I'm like, I made that. That's cool, you know. So that's my background.
And Melissa's now working at?
I work at Asante Physician Partners Family Medicine Clinic in Talent. I'm the practice manager there. So.
And are working to create a similar program there in an agency where that program is really underdeveloped, if not at all.
Yeah, I mean, I would say so Asante Physician Partners APP is actually really kind of a baby organization. We're about 4 years old, and so one of the things that happens when you're first developing a large family practice group is that sometimes policies and procedures kind of come after the fact, and so one of the things that we've found is that we don't really have an effective way to manage those patients. And we have some guidelines in place, but it's more like we're running kind of a drug monitoring program than we are really looking at quality of life for these patients. And so really trying to get some of those tools into place to make sure that we can start looking at this kind of at a systems level.
Thank you. I just wanted you all to meet Melissa. I think she's an amazing resource, especially for those of you that are starting to bring these programs and develop these systems in your own clinics. She's got a lot of wisdom. So our next area of focus is really going to be on provider values. And so one of the things, or care team values, so one of the things that we have found in the work that we've been doing in Southern Oregon and with a couple other folks around the state is that it makes a huge difference if the provider, if we believe that what we are asking of our patients is in their best interest. And I think that, so if you don't believe it, or if you feel annoyed that somebody else is making you do it, or the outcome is very different. If you believe, and I have the opportunity to experience this as a parent every day. If I believe that telling my daughter no about something is really, nope, you can't spend the night 3 nights in a row. And if I know that really it's in her best interest to not spend that 3rd night, my ability to tolerate her kicking, her screaming, her anger, her beratement of me is way higher than if I don't really care, or I don't know if it's a good idea, or I'm just sort of saying it out of some principle or something I read somewhere. So yes, I read this article years ago when my daughter was probably 5 and she's now 14, and it was called Giving the Gift of No. So some of what I think that we're talking about here is giving the gift of no, or as you said earlier, Rachel, it was focusing on, I wrote it down, it was focusing on the things that we know are going to support healthy outcomes rather than the things that we don't know that might have adverse effects. So there are many situations that I have the opportunity to observe now where the prescribing provider that is having the conversation with the patient for whatever reason actually is ambivalent about whether or not tapering these medications is in the patient's best interest. And so there's clearly a whole piece of work to do around that, which again we will not be focusing on today. But there's this question, like how do we do that? How do we move a prescribing provider to a place where they might see that differently, or they can stand behind some of the reasoning with these policy changes? So there's a lot for us to explore there. For the sake of this conversation, I think it's just important for us all to reflect on what are our values. What are our values in this work? And what drives you to this work? What brought you to this in the first place? What is meaningful to you about your relationship with your patients? What do you want to support in your patients? Taking some time to reflect on your values, and then to use those as kind of like a support when you are entering into conversations with patients that can be challenging. So I think that the other thing here, I think, is this can really, if you are connected to your values, it can be very supportive in shifting your perspective on what an effective outcome is in a conversation. Another thing that I observe regularly is that there's just this fear that if a patient leaves, or this idea that if a patient leaves an appointment angry, the appointment didn't go well. So here, the thing I think that I'm asking for here is this kind of an idea that there is a shift in perspective about that, a shift in perspective about what a successful visit looks like. There's this little, are any of you familiar with this? Okay, so I think that one of the things that really kind of informs successful conversations between patients and providers is our being willing to step into having a new perspective about something. So we have a job to do here with getting our patients to start to have a new perspective on what other forms of treatment are, and providers not only having potentially a new perspective on other forms of treatment, but also a new understanding of patient responses, a new understanding of, let's say, what an effective appointment is. And in some cases that really might be that a patient leaves angry. And if you know that in your heart you have given the gift of no, or you've given the gift of I'm going to be standing behind what is in your best interest at this time, that somehow it can make it easier to navigate that. And what tends to happen is we have our initial tendency, like when I first look at that, I definitely see a vase. I think each of us probably look at that and see one thing first. Some people might see the profiles first. So what happens in this process of change is that we've got kind of like our baseline. The vase is my baseline. Then I might get some new information where I start to be able to see the faces. But actually when I get stressed out and overwhelmed, I'm going to go back to my baseline of seeing the vase. So a lot of times, if you're going to be starting to have that conversation with patients and the patient is really getting irate and calling you a bunch of names and super mad and you've ruined their life and you don't care about them and they're going to kill themselves and blah, 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 it's pretty easy to just go back to whatever your primary form is and take out the slip and write the script and just get that over with. So what we're asking for an increase, something hard. It's like really an increase in distress tolerance, both for the provider and for the patient. Okay, anything else I want to say about values here? Okay, I think not on values. I'm going to switch now to kind of reflecting on the patient experience, which I think, here's the drug addict one. So I don't know if this rings a bell. It does? Okay, good. So I cannot even believe how often I hear this. And actually, this is what I had this like middle of the night, I don't know, manic episode a few weeks ago where I've been thinking about this because I hear this across the board from patients, which is just like as soon as they hear that they might have to taper, there is this instant, reactivity. And the thing that I hear more than ever is it's the drug addicts that are making the feds change their policy and take my pills away. And I've been trying to figure out how to really kind of interrupt that or open that or create the possibility that a patient might consider something different about what's going on. To me, that really kind of, what I'm finding is that it's a really important thing to understand that when we are even considering the possibility of taking a patient's meds away, that those medications have been their only form of treatment in many cases that have been taking away their physical pain, their psychological pain, and their emotional pain. These are not, and the idea that they are going to no longer have that can be so re-triggering, can totally send a person into a state of feeling like nobody cares about them, like they're being sort of pigeonholed, like they're not being seen for who they are, like it's terrifying. It's really terrifying. So the cases that come to mind, probably because of my orientation and what my work drives me to, are cases where people have experienced a lot of trauma. However, you don't have to have experienced a lot of trauma to have the experience of not loving to hang out with uncomfortable feelings. And I think that this idea, it's a really tough sell to convince people that their lives are going to be better if instead of turning away from the tough stuff, they turn towards the tough stuff. So that is a really hard thing to convince people is a good idea to do. And so But that is what I would say that this work is really about. It's this idea that actually there's a possibility, and in fact there's a really good chance that if you can develop the tolerance to be with those uncomfortable feelings that those medications have been masking, that ultimately your quality of life is going to improve. Your ability to stay connected to the things that are meaningful to you in your life with your pain is going to improve significantly. And this really asks for a focus, a shift away from this idea that we need to get rid of our pain, that pain is bad. Everything in our culture really supports that. If you're not happy, there's a problem, which is a problem because it just doesn't work like that, it turns out, at all. We need the whole spectrum of our emotions. We need our grief, we need our anger, we need all of those are tools that work for us when they're working for us. And we have been so programmed to just, and I see this happen really oftentimes in the dynamic between prescriber and patient. That is the one powerful dynamic, to be able to say, I am in the position of being able to take your pain away. You know, if a provider, that's a hard thing to ask. You know, it really takes, for a provider to shift gears off of prescribing high doses of opioid medications, it means that provider has to taper off. It can taper off of a feeling of, it can increase a feeling of helplessness. It can, you know, what am I supposed to do then? I've been trained to do this thing. There's a problem and I'm supposed to fix it. There's a problem, here's what I've been trained to fix it. And now all of a sudden we're saying, actually something else is being asked here. You're being asked to actually model for your patients that it's possible to be with their pain in a different kind of way, and that you have the ability to tolerate being with their pain in a different kind of way.
I think it's interesting because as you were just saying that, I couldn't tell if you were talking about the patient or the provider's perspective. Mm-hmm. I think it's important to remember that, like, it's a struggle for providers, but it's also a struggle in that exact same way. But wait, this is what I've been trained to do.
Absolutely. Absolutely. And not only trained to do, you know, there's been this whole pendulum swing over time, but not so long ago, prescribers were getting in trouble if they didn't prescribe enough pain medications. And if you don't have a lot of like downtime to be reading up on current research, and all of a sudden next thing you know you're getting in trouble by the medical board because you're prescribing too much, you know, that's a lot. So what I want to do here is paint a quick picture of this exact thing that we're talking about, the patient-provider relationship, and then we're going to break off and do a little practice. I last year was asked to go and meet with a provider who had lost his license for prescribing because of unsafe prescribing. And I went into the clinic and I had to do a little training with those with his staff, and then the idea was that I was going to do a couple of shared visits. This provider had identified, I think maybe 4 or 5 patients that day that he thought of as being really, really challenging cases, and the idea was going to be that we were going to meet with those patients together, because he was going to break the news that he was not going to be able to prescribe these medications to them anymore, and he was concerned about how that was going to go. So I did this little blurb with the staff, and one of the areas of focus was really about shifting our perspective of what a successful outcome was. And I said, if you expect that your patients are going to be leaving this appointment singing Kumbaya, you've got another thing coming to you. Okay, that's very likely not going to happen. So the first patient, he kind of debriefs me on the first patient, and the first patient's their story is that 7 years ago, she and her husband were in a car accident, and the husband died. And at that time, she had some kind of back injury, and he put her on opiate medications. And this man has a heart of gold, kindest man you have ever met in your life, loves his patients so much, like sweetest, sweetest, sweetest gentleman. So he, meanwhile, over the course of 7 years, she's on some astronomical amount of opiate medications. And so he is just mortified at the idea of having to go in and tell her, like, I'm not going to prescribe you these medications anymore. He feels all this guilt about the fact that she's on these high doses as a result of him. And meanwhile, at one point he says to me, if I had just encouraged her, or he said something like, I really think that if she had grieved the death of her husband, back then that we wouldn't have gotten into this position in the first place. So this is what he says to me before we go into the appointment. So we go into the appointment and I'm sitting there, and so sweetly they're holding hands, and she starts to talk about her mother's recent death and how her mother's recent death has brought up a bunch of this grief about her husband's death. And then he breaks it to her that he's no longer going to be prescribing these medications. And she just goes, "You mean you're not going to be my doctor anymore?" And he goes, No, I'm going to be your doctor. I'm going to be here with you through this whole process. It's just that we need to start working on getting you off of these medications, and I think that it's going to be really better for you overall. And she just, like, this huge sigh of relief started to happen, and she just said, "Oh my gosh, I don't care about the medications. I just want you to be my doctor." And at that point in time, he started singing Kumbaya. And this was like actually the first time I'd ever done any of this. This was my first like shared visit officially with a doctor, and I was like, "Oh my gosh, this is awesome." And we got, the whole staff came in and everybody was singing Kumbaya because we had just done that training. And the patient, it was really like an amazing, amazing thing. Okay, the next 4 sessions were not like that. There were some like homicidal threats, whatever. But point is that to me that just illustrates that unbelievable power that I think providers forget. All of us forget that actually committing to our patients that our relationship is a huge thing to offer. Yep, we're going to be taping you off these meds, but I'm here for you. I believe in you. I'm not leaving you. That is really huge. And okay, I think you got some handouts in front of you. I'm going to have you break into groups of 3. And I'm going to have you what I would love for you to do would be to really, in your own time, maybe to do some writing, really reflect on what your values are that inform this work that you do. Okay. I really do encourage you to continue reflecting on this piece because I think it's really a powerful aspect of what we bring to the table. Those you can keep writing if you want, but I'm going to just shift here and introduce this model that comes out of the VA in I believe it is Seattle, which is validate, educate, motivate, and activate. And what I really want us the focus for today is going to be on this validation piece. The idea is that if we do not validate our patient's experience, they will not be able to hear any of the parts that you want to educate them on. So when the patient is saying, "It's the drug addicts that are making the feds," blah, 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 or "I'm so angry," or "I can't believe you're doing this to me," until they have the experience of being validated, you are not going to successfully be able to be like, "Wait, look at this great research that we have on," or "Here's this handout," or there's no way they are going to be even able to hear it at all. There's just too much going on. And I think that what happens often is that we tend to want to go strict right to, "Okay, so this isn't good for you anymore, and here's our plan, and here's why," and we don't spend enough time in this validation area. So what it can look like on the front end is that takes a lot of extra time. The reality is that if you don't start here, things get super hectic, and it's going to take a lot more time long term. So oftentimes what can happen is you can give it kind of enough validation, and then you can start to move a little bit into educate, and then the patient might get flooded, and you got to go right back down to validation. So I've handed out 2 pieces of paper. These are drafts. The Oregon Pain Guidance folks down in Southern Oregon have come up with guidelines that they are in the process of revising. The centerfold of those guidelines, which some of you may be familiar with, is focused specifically on having difficult conversations with patients. So we are in the process of kind of revising those guidelines. You all are the first to see this working draft that we have going on. But I encourage you to look over those. And you'll see that at one point there's that description of the validate, educate, motivate, and activate. So here, I think the real take-home is that if we do not spend enough time validating a patient's experience, that it is really nearly impossible to move forward. And so the topic of this portion of our today's, or the title, was really how values and validation support change. And so that. Do you think we have enough time for a little breakout? Yeah. Dyads? Okay. So what I would love us to do would be to just do a little bit of practicing. Maybe do each of you have a patient example of a patient that you know is unhappy about needing to reduce dosages? Yeah? Okay, so can you really one of you pair up and one of you really think about that particular patient. And what you're going to spend time with right here is just simply the validation process. So one of you be the provider and one of you be the patient. And we'll take 3 minutes to do this. Okay. Does anybody have any reflections about that experience of the role play that they would like to share, or? Yeah.
Joanne and I were talking about the fact that you have to replace it, that you can't just leave your patients high and dry, and that so often in that conversation when you say like, you know, we're going to discontinue these medications, we're going to taper you down, that's all your patient hears. So they're like, well, I believe that that's what I need, and now you're taking my only coping skill away. And that so often we don't have the conversation of what's next or what else we're going to do.
How are we going to support you, or we're here for you to go through this process.
Did you come up with some ideas together about how to do that?
Well, the nice thing about our clinic is we have behavioral health specialists who does work with people like that. But that's what it's going to take. I mean, it's going to, the provider unfortunately doesn't have a lot of time.
Absolutely.
They have that time, but having a behavioral health specialist who actually can address those issues is a really vital part. Because there's a reason people are needing this medication. And you just said that they have to face their pain. Well, it's hard for a person to face their pain by themselves.
Absolutely.
I mean, they need that relationship. So that's something, I mean, we have a short-term behavioral specialist, but there needs to be upped the mental health stuff on the outside.
Yes.
So,
and so some of that,
it's all part of this process.
Yes. I think that really is, and so, really being with the patient in the moment that you're saying that, acknowledging that it can feel like they're coping, their only needs of self-care really is being taken away from them, and then letting them know that that you are going to partner with them and coming up with some other strategies, and ideally there are some of those other things available, whether it is referral to some kind of counseling service. There are, I think, more and more these programs for folks with chronic pain that are happening around the state, having handouts about whatever cognitive behavioral therapies, et cetera. Hopefully we're going to start seeing this upsurgence even more of other opportunities or other treatments for.
What's got to happen for taking people off?
Absolutely.
I think even before we consider taking people off, we have to, we very carefully have to think about providing patients with coping skills, or at least just one skill that they can work on before we even talk to them about tapering, so that they have some confidence in that skill and in being able to better handle that. Because if you're just saying, like providers saying, okay, we're gonna have to take you off, and the person does literally have no other skills, no other coping skills for managing pain, you're leaving them high and dry, and you're really doing a disservice to the patient.
They're headed out to the streets to get heroin to replace it.
Well, and it's also a mistake to just hand it to the BHC and say, here you're going to meet with someone, and this is what we're going to give you. As a BHC,
I wanted to speak to that a little bit too, because I mean, I'm absolutely an advocate for behavioral health integration. I think that should happen everywhere, but it doesn't. And so I think that's really where it kind of drives the core idea that it's about care team values. So yes, maybe the provider doesn't have the opportunity to have as much of a conversation as you want them to have, but this should really be something that is being addressed at every level of your care team. So whether that's your PSR, your nurse, whoever that may be, like everyone should be sending that same message. So if you have behavioral health, that's awesome, that's great. But everyone should be delivering the same message and be on the same page about how we're going to take care of these patients.
So Rebecca and I were talking, mostly Rebecca was talking about the tone of voice she uses when confronted with those difficult situations and validation. And I thought that was really powerful, just talking about how, yes, I can see that you're upset and let's talk about this. it sounds like it sucks. And just having that complete, basic honesty and just kind of throwing back what the person's giving to you. And I think that's probably something I'm going to keep in mind when I talk to people now, and just make sure I'm not going, okay, yeah, I know you're upset, and we can definitely work on this, and not trying to escalate it into a voice too.
Also, rate of speech. I am from the East Coast, and I feel like I talk fast. Just it's kind of how I roll. But I found that like making sure that you're taking time just to, keeping your tone very moderated, and then even when you hear someone getting aggressive or getting kind of upset, just making sure that you're coming back in a calming manner, because there's definitely like people are able to kind of just respond positively back to that. If you escalate with them, then you're both just going to explode.
Absolutely, that self-regulation.
Is it okay, like sometimes they just kind of come, I've had comments where sometimes the only way I can like validate or reflect is just to say, and I don't know if this is the right thing to do, but it's just say like, I'm sorry that you feel that way. I don't know if that.
Yep. You seem really upset. I'm sorry that you feel that way. I can imagine that this is really hard for you, really naming those emotions. So what I want to say is I'm sorry that the time started to feel so tight. And everything that you're bringing up, I think each piece that you all are bringing up is something that we could spend a really long time talking about. There's so much to this, and there's a lot here to discuss. So how do we really create those alternative supports for patients? What does it look like to de-escalate a patient? How do you get the patient engaged in their treatment plan? So we just focused on those two little slivers today. Thank you so much.